Congenital hypothyroidism is a significant pediatric condition and the most important preventable cause of mental retardation. Unfortunately, most children with congenital hypothyroidism is still in the resource poor country that diagnosed at a very late stage when nothing much can be done and already the intellectual deficit has happened. On the other hand, with the plethora of easy availability of thyroid profile tests, there have been situations wherein treatment is started at a stage when it is not required. So, therefore, we need to be cautious both with regards to not missing the diagnosis of congenital hypothyroidism on one hand, but also not unnecessarily treating those children who do not require thyroid replacement. So we'll go through the when, why and hows of congenital hypothyroidism, and I think all of us know about the classical clinical picture of congenital hypothyroidism as depicted on this child. We have the coarse facies, prolonged jaundice, skin coarse, umbilical hernia, wide open anterior fontanelle, posterior fontanelle, and all textbooks in pediatrics have this classical picture. But what we aim for is to not pick up a child when the child develops these features. It's already too late. So we should be more proactive in terms of evaluation and pick up the child at this stage with subtle symptoms like maybe hypothermia, bradycardia, and most importantly, no clinical features. Vast majority of pediatric endocrinologists are unable to identify even complete thyroid agenesis in the first 2 weeks of life. And this is the critical window of opportunity at that point. If we act, we can preserve the intellectual outcome of the child. Otherwise, the child is going to develop significant intellectual delay. And therefore, there is a definite case for screening. Now, often we are asked question as to whether we should be screening with regards to hypothyroidism. The answer to that is that we should not be discussing about whether we should screen, but how to screen and how to go forward from there. Just to put the arguments forward, to be an effective screening strategy, we need to have a disease which is relatively common, has significant impact on the individual and society, gives us a lead time in which one can act to prevent those complications, and has a robust test. Based upon this, we can detect the diagnosis with a good sense of precision and accuracy. So if we put hypothyroidism in this regards, regarding congenital hypothyroidism, we see that it's a relatively common condition with a figure quoted of around 1 in 1500 in Indian children. One of the most important high impact endocrine diseases in children with leading cause of mental retardation which can be prevented. Gives us a lead time of 2 weeks in which if we intervene we can save the intellectual outcome of the child, and a very robust test in the form of TSH is available which can be done and would help in terms of diagnosis. So I think there is no confusion that every child should be screened for congenital hypothyroidism. Now, the other issue which is often causing a lot of concern and confusion as to when to do the test and what would be the best cutoff to use. Now, we have discussed already in the physiological assessment part that there is a TRH surge after birth, which results in significantly high levels of TSH in the initial phase, which may go up to 40 milliunits per liter, which subsequently the levels tend to decline and the 95th percentile gradually comes down. So the best time to do a thyroid screening test is after 72 hours of life, by the time the TRH surge is more or less gone. But even if you're doing at that time, a capillary blood value of more than 40 only should be considered appropriate for treatment. And even in that stage, it would be better to actually confirm with a proper venous sample. If the levels are more than 20 milliunits per liter beyond day 7 of life, we should consider treatment, while beyond 21 days, 6 milliunits per international unit should raise concern and we need to evaluate and manage. So we'll go forward regarding the different recommendations as far as neonatal screening is concerned, and this is a very landmark publication from American Academy of Pediatrics. And though this looks like a busy slide, I'll just go forward towards the key messages. Now the first question that comes to our mind is that which screening strategy should be used, whether we should be using cord blood or a postnatal sample. And what they're saying is that actually day 2 to 4 and ideally day 72 hour sample is the best sample to take. In situations wherein we are not able to get the child back at the time, we can actually use the cord blood sample. And ideally, and in an ideal situation, we should use both a T4 and TSH strategy, because this will pick up both primary as well as central hypothyroidism. But in a real world, this would increase the cost tremendously if you talk about population-based screening, and when we are not even doing a TSH sample alone, so maybe T4 TSH would be going a bit far in that regards. So most situation it will be the TSH alone strategy, and if we have a capillary TSH value more than 40, we have to start treatment. If the situation is borderline, is less than 40, it may be ideal to repeat after 2 to 4 weeks. And there is some controversy regarding that, which I'll try to simplify a bit later. And they suggest that if the levels are more than 9.1 beyond 2 weeks of life, we need to consider possibility of treatment. We need to understand the other situation is that if the TSH is borderline elevated, again they quote a figure of more than 10. So 9 to 10 seems to be a reasonable picture with regards to these guidelines. What about the latest guidelines? And now we have the European Society of Pediatric Endocrinology and a combined guideline of all the societies across the world. And it clearly says one thing for clear: if the capillary TSH value are more than 40, we should confirm and start treatment immediately. On the other hand, if you are doing a follow-up TSH, and if it's a venous TSH values more than 20, merit treatment. And the major cause of confusion is between 6 to 20. And in this regards, between 6 to 20 milliunits per liter, it would be depending upon the discretion of the treating physician, discussing with the parents about the possibility of the effects and benefits of treatment, and maybe doing a nuclear imaging just to make sure that there is not a mild form of dysharmonogenesis or a hemiagenesis which may result in transient or a mild elevation of TSH. So that remains to be a gray area. So just to summarize these guidelines. So to simplify things, if you look at the TSH levels, if they are more than 40, no confusion, start treatment. If the TSH levels are between 20 to 40, best would be to repeat the levels after 2 weeks. If the levels persist beyond 20, treatment should be started. Between 6 to 20 is a gray zone, and most clinicians will advise a follow-up in this regards. If the levels are less than 6, no treatment is required. On the other hand, the initial TSH is less than 20, we don't even need to follow up in that setting. So I think the cutoff of 40, 20 and 6 will give us a reasonable idea. If we are more conservative, we can use a figure of 10 instead of the 6 as recommended by the AAP in the earlier recommendations. So now we will have a 36-year-old girl who presents to us with TSH of 60. So what do you do in this setting? Does she require treatment immediately? No, because we've taken the sample a bit too early, and there are situations wherein if there is an early discharge from the hospital, we do have to take sample at an early stage, but then we have to use age-appropriate cutoffs, which are often higher. So in this girl, once we repeated the TSH levels after 2 days, they came back to normal. So this does not require treatment. This is not hypothyroidism by any stretch of imagination. 4-year-old girl who presents with TSH of 24, which is mildly elevated as we discussed, it's less than 40. So what do? We'll repeat the level. At day 10, the TSH level has now come down to 18. So it's come down slightly. Do we need to start treatment? Maybe not. So we'll follow up. And day 21, what we are seeing is the TSH is still hanging around the number of 10. So this child seems to be pushing with regards to the thyroid level. It's not coming down to normal as expected. So it would be a clinical guideline and a clinical judgment as to decide whether treatment is to be given or not. In this case, we actually did a thyroid scan which showed hemiagenesis, which is a milder form of thyroid dysgenesis, and it is appropriate to start off treatment in this situation, mentioning that maybe this child may come off treatment after some time later on. So now we'll go forward to the next issue about why does congenital hypothyroidism happen, and we are all aware about the hypothalamic pituitary thyroid axis, and the most common cause of congenital hypothyroidism is actually primary hypothyroidism, accounting for more than 98% of cases. the most common of which is thyroid dysgenesis, followed by thyroid dishormonogenesis. Iodine deficiency is now emerging as a minor cause of congenital hypothyroidism, especially in non-endemic areas, and it's dysgenesis which is most important. Children with thyroid dysgenesis have a most severe form of thyroid failure. They present with TSH levels which are extremely elevated, who often have fetal hypothyroidism with absent knee epiphysis and need to be started off at a very high dose of treatment. Dishormonogenesis, because it represents abnormality in the enzyme and the biosynthesis, may have a variable presentation in which the levels may actually be mildly elevated to severely elevated as far as TSH is concerned, and these individuals may be started on at a lower dose of therapy. Some of the dysharmonogenic disorders are inherited and they run in the family and are associated with other abnormalities like cardiac malformation or deafness, which is commonly in the setting of pendrin deficiency, which is Pendret syndrome. We should always be aware about transient causes of hypothyroidism, which will account for around 5% of cases, including iodine deficiency, iodine excess, and passage of TSH receptor blocking antibody from the mother to the child. Central hypothyroidism is rare in the neonatal period, usually occurs in the setting of hypopituitarism. Isolated TRH deficiency is extremely uncommon and should be suspected in the presence of midline defects and micropenis. And I would not even mention about T3 resistance because that will further complicate given the very rarity of that situation. So now we know when to suspect and why does hypothyroidism happen. The next issue is how do we proceed from there. So further assessment of a child who has congenital hypothyroidism should include at least a nuclear scan, and if it's not feasible to look at ultrasound thyroid. Nuclear scan provides information about not only the anatomy of thyroid gland in that it may be showing no uptake in situations of dysgenesis, ectopic uptake at the level of sublingual gland in setting of ectopic thyroid, or increased uptake in the setting of iodine deficiency or dishormonogenesis. It also has information about the functionality as discussed about, particularly in the dyshomogenetic state. Ultrasound thyroid is a reasonably good anatomical marker of thyroid gland, and it's often not difficult as we often perceive to pick up a eutopic thyroid on a routine thyroid scan. Knee X-ray should be done to look at possibility of fetal hypothyroidism, particularly if the initial TSH levels are extremely high. We should also look at the hearing, cardiac, and developmental examination to look for associated abnormalities which are found along with the congenital hypothyroidism, particularly deafness in the setting of Pendret syndrome and cardiac dysmorphism, which is often observed. Children who have central hypothyroidism, particularly in the setting of midline central defects, micropenis, hypoglycemia, prolonged jaundice, who have low FT4 and borderline elevated or normal TSH levels should be evaluated for the hypothalamic pituitary axis, particularly with the cortisol level before starting treatment, because otherwise if we start treatment, they will develop acute cortisol deficiency and have significant abnormalities and problems. So we should do a nuclear scan, and if the nuclear scan shows no uptake, it is not just diagnostic of thyroidogenesis. Look at a thyroid ultrasound. If the ultrasound also shows no thyroid, we should think of a possibility of dysgenesis. However, if it does show the thyroid, there could be some other conditions which can actually block the action of TSH receptor or iodination in the form of TSH receptor antibodies, sodium iodine transporter defect or TSH receptor defect, which may present with absent thyroid gland noticed on scan, but when we do an ultrasound, we are able to identify that. This condition is particularly noted in transient hypothyroidism in the setting of maternal autoimmune thyroid disease and transplacental passage of TSH receptor blocking antibodies. On the other hand, if we have ectopic uptake, it is highly suggestive of ectopic thyroid. This condition can also be suspected if we have a midline swelling at the level of the submandibular region, and that diagnosis is pretty evident in those cases. If there is increased uptake, we should think of a possibility of iodine deficiency and dysharmonogenesis in this regards. The management of hypothyroidism is pretty straightforward. If we diagnose at an early stage, we should treat immediately after the further classification workup has been done. In children who have central hypothyroidism, we should exclude ACTH deficiency because treating T4 would cause problems. Otherwise, if we are missing cortisol deficiency, the dose of congenital hypothyroidism is much higher compared to the adult dose of 1.6 microgram per kg per day. It is around 10 to 15 microgram per kg per day, with the higher dose being used for children who have complete agenesis and lower dose in the setting of dysharmonogenesis. It should be used only in a tablet form, which should be crushed and dissolved in breast milk. The doses are adjusted based upon the thyroid functions, which should be done monthly in the first 6 months and twice monthly thereafter. We should always do a FT4 and TSH 2 weeks after starting the high dose therapy with an aim of restoring FT4 levels in the normal range. The aim is to maintain FT4 in the high normal range and TSH in the normal range. Having said that, in children who have prolonged congenital hypothyroidism, particularly fetal hypothyroidism, may have a reset hypothalamic pituitary thyroid axis resulting in persistent elevations of TSH, and these children may not require increasing doses even if the TSH levels are marginally elevated, provided FT4 is in the high normal range. Only after 2 years of life should we consider and rely only on TSH levels, otherwise FT4 is also extremely important. The duration of therapy in most cases is lifelong. In certain situations like iodine excess, TSH receptor blocking antibodies, it may be transient, but unless the TSH levels are very low and the body itself is showing it doesn't require thyroid replacement, it's best to continue till at least 3 years of age. At that point of time, we can give a gradual tapering of thyroid hormones and then remeasure after 6 to 8 weeks, and the TSH levels are going beyond 10, the treatment should be continued for life. Otherwise, we can withhold treatment with periodic assessments subsequently. So now we have a 4-day-old boy who had a TSH of 64 and scan did not show any uptake. Was started on 15 microgram per kg per day, but low TSH was noticed within 2 weeks. The dose was reduced, and very quickly, even at minimal doses, the TSH levels remained low, indicating excessive treatment, and treatment was stopped, following which the TSH remained normal. So what's the diagnosis? Is it thyroid dysgenesis? No, because in thyroid dysgenesis, this should not happen. We may have some reduction in doses, but we will not be able to take off treatment at all. So once we did an ultrasound, we found that there's a normal thyroid, and this was a maternal autoimmune thyroid disease with maternal TSH receptor blocking antibody. So this is a classical situation of thyroid agenesis, where because of TSH receptor blocking antibodies, we may have an apparent agenesis like picture, but it is actually a eutopic thyroid, and once the antibodies go off, the child becomes euthyroid even without treatment. 12-day-old boy presented with prolonged jaundice, FT4 is 6, which is on the lower side, TSH mildly elevated. Started on thyroxine at 50 micrograms per kg, 50 micrograms per day, which is a pretty high dose, and suddenly the child deteriorated, had to be admitted into the ICU. So this is a classical picture of central hypothyroidism in which the FT4 is low and TSH is marginally elevated. In this setting, we also noted the child actually had micropenis and the cortisol levels were low. So individuals who have central hypothyroidism, who have midline defects, who have micropenis should be evaluated for associated pituitary hormone deficiencies before starting treatment in this regards. 4-month-old girl on thyroxine 50 micrograms. FT4 is on the normal range, but TSH is persistently high. So do we need to increase the dose here? Is often a question. When we retrospectively review this child, the TSH was extremely high, more than 100 at birth, and it appears to be a reset hypothalamic pituitary axis. TSH may take time to come down, and therefore we advise no dose change, and 6 months of age, the TSH had come down. So in these situations who have prolonged hypothyroidism, we need to be a bit patient in terms of TSH levels to come back, and should not be very aggressive and don't chase TSH levels, particularly the FT4 levels are in the high normal range in this regards. 3-year-old girl diagnosed at day 6 of life with regular thyroid functions, good compliance, maintained TSH throughout this period. Yet the parents are very concerned about speech delay, and in this regard, when evaluation was done, it showed an abnormal beta suggestive of hearing defect. And so this, the diagnosis is very clear, is a rare situation of Pendred syndrome, wherein we have a concomitant hypothyroidism and a hearing problem. So just to highlight a few points about congenital hypothyroidism, we should do screening in all children who have congenital hypothyroidism, work up for an underlying cause, high dose treatment is recommended with regular checkup and follow-up.